Welcome everybody to our first Pull Up a Seat, shining a light on the experiences of Black women with breast cancer. This event is co-hosted by Tigerlily Foundation and GRASP, and you'll be hearing about those organizations as we continue. So, all right, so the agenda for today, as you can see, we have quite a few items, 9 to 10 right now. We're gonna, I'm welcoming you all an introduction. My name is Shonte Cooper, and I am the Diversity and Inclusion Manager at Tigerlily Foundation. And I'm also going to share with you 5 agreements just to set the tone and create a safe space for us to be. And then we'll have Mema Carmo, the founder of Tigerlily, give our reason for Pull Up a Seat, followed by GRASP co-founder Julia, who will also provide about the mission of GRASP. And then we'll have our keynote by Dr. Arnethea Sutton, who is at VCU, Virginia Commonwealth University, on clinical trials and HCP practices. And then we'll have an engaging section time from 9:40 to 10:20, where we'll exchange ideas led by our Black patient experts, who will be introduced as I go further on, and the attendees. And that section will be, the breakout rooms will be 10 minutes. We'll have introductions by our Black patient experts, and they will share their stories, why they are here and why it's important for them to be here. That'll be for 10 minutes, and then we'll have a conversation between the participants within the breakout room. And then 5 minutes before towards the end of that, we'll have ask the Black patient experts to just, give a summary within your group just to make sure that all the ideas have been recapped and that we can share it in the larger group. So 10:20 we'll reconvene to the main meeting room. And from 10:20 to 10:40, we'll have 20 minutes to really connect the data and real stories. We'll have Dr. Sutton lead that conversation, and we'll hear feedback from each of the breakout rooms from our Black patient experts, followed by the way forward. What are we planning with the next steps? And we'll also share a brochure that our very own Sheila McGlown, who is one of our Black patient experts, created to serve as a guide for a tool that women can take with them, Black women, as they enter into, as they go to speak with their healthcare professionals. So we'll have that, and then 10:45 to 10:55, we want to hear from you. It's open up, audience feedback. Let us know what you think, your thoughts about the experience, and then we'll close with 5 takeaways for participants, and that'll be the Friday. So again, thank you guys for coming. So we have, as our Black patient experts, we have Sheila McGlown, Jamil Rivers. Okay, I apologize, Jamil, that your last name is misspelled. Angela Jersey Baker, Roberta Albany, Nunny, Reece, and Shonte Drakeford, who will introduce themselves, and Dr. Arnethea Sutton, who's a postdoctoral fellow at VCU, Virginia Commonwealth University School of Medicine. The 5 agreements, so how to be in conversation. Monitor your airtime, speak your truth, speak from your own experience, lead with curiosity and not judgment, and keep the space safe. So our reason why we're here today. So since March of 2019, in collaboration with our strategic partners at IRIS Collaborative, Tigerlily Foundation has reached more than 200 million people from rural to grassroots and global communities through the following disparity initiatives. In March 2019, we convened women of diverse ethnic background and stakeholder communities to listen to and learn from the perspectives of Black women at a Young Women's MBC Listening Summit. In November 2019, we launched an MBC Disparities Advocacy and Educational Outreach campaign and launched our Young Women's MBC Disparities Alliance on Capitol Hill in partnership with grassroots, state, and local, national, and global health partners and policymakers at our 7th annual Young Women's Breast Health Day on the Hill. And we focus on disparities in science at SABCS. In December 2019, we held a historic event, which was the largest convening of women of color, specifically Black women, at the largest global breast cancer scientific gathering. Tigerlily Foundation's Fireside Chat brought the voices of young Black women to SABCS. our NBC Angels experts and industry leaders gathered to identify barriers, solutions, and pledge to end NBC disparities and create access for women of color. We also partnered with GRASP, bringing together a record number of Black women together with scientists for poster sessions. And we mobilized. In January 2020, we assembled a cohort of 20 Black women representing cities in which Black women have the highest mortality rates for a year-long intensive and immersive program that addresses systemic barriers, social determinants of health, social competencies, mistrust, and mobilizing these young Black women for outreach and impact in their communities where they live and work. So these are examples. These are our wonderful NBC Angel advocates, and they represent 20 areas of impact. As you can see from the map, that includes Memphis, St. Louis, Dallas, Fort Worth, Los Angeles, Virginia Beach, Atlanta, Chicago, Washington, DC, and the list goes on. So those are some of our advocates. And in May 2020, at the ASCO Confab, with our second scientific immersive activation, we brought together scientific communities and Black women for a powerful and culturally focused virtual learning experience focused on the needs of Black women engaging with the scientific community. And we activated. In June 2020, we launched the Diversity and Inclusion Pledge on change.org, and we actually have more than 11,000 signatures. This needs to be updated, but that's on me. This pledge is bringing about systemic change at every level of our healthcare system as it affects Black women. And that brings us to today, no more disparities and pull up a seat. So 2 weeks ago, we held the No More Disparities conversation, which was facilitated for and by Black women, which created a safe space for honest conversations with Black physicians, patients, and medical clinicians to discuss their experiences of health and inequality, implicit racial bias, and lessons learned. Together, we said no, we continue to say no more about disparities so that we can, as a collective, say no more to disparities. And 2 weeks later, today, we are having our first Pull Up a Seat, which is a conversation that will be co-hosted by Black patient experts and a Black doctor that will amplify the voices of Black women through candid conversations led by a Black keynote physician or a medical clinician on racism in clinical trials and practices, on equal treatment through all stages of breast cancer, and to determine solutions to the high mortality of Black women. So I'm going to turn it over to our Y and the founder of Tigerlily Foundation, Mema Karmo, to share a bit more about why we are here today.
Good morning, everyone. Hope you guys are well this morning. I haven't prepared a talk. I always speak from the heart. I'm really deeply honored to have you all here today. Thanks to those who are watching in the background who are not on the screen for your friendship and allyship. This year has been a cluster of a year with all the racial tension and with COVID. It's brought to light many things that people have held for a long time under the carpet and have not wanted to discuss, especially Black trauma and pain around racism and equity and health. And also, you know, we're able to now use our voices on a platform that we haven't had before and have the freedom to do so in multiple ways. I'm really proud of the advocates who are on here because you're all going through treatment or in some way, living with your own emotional trauma and needs, but yet giving your voices and time to consistently throughout this year, whenever you're called upon to share your experiences and share your trauma and speak your truth to power over and over again. I want to thank our allies of every color who are going to be note takers. This is a really important conversation. For us to figure out how to eradicate disparities and end barriers, we have to address the underlying traumas around why things are happening, the underlying mistrust, and we have to look within ourselves deeply and figure out where we have biases and how we can work to eradicate them. And so I'm proud of all of you for being a part of this, for this program design. Thanks to our supporter and sponsor, CL Genetics. And Christine and Julia for stepping up as white allies who have said to us, you know, we want to be better and want to do better and work with you to end disparities. So I hope you guys have an amazing conversation. I'll be watching in the background, supporting you with love and holding a space for this to be really transformational. And so with that, with no further ado, let's just have at it. Have a blessed session, guys.
Thank you, Mayma, and thank you, Honey and Sugar, for chiming in as well. Okay, Julia, we'll have Julia share about GRASP and their mission.
Yeah, so thank you everyone for being here, and thank you, Mayma, for really taking us on as allies, for teaching us patiently on everything that we are learning from when it comes to our privilege as white women. So Christine Hodgson and I co-founded an idea called GRASP. It stands for Guiding Researchers and Advocates to Scientific Partnerships. And we inaugurated it at the San Antonio Symposium last year, back when we could meet in person. So what happened is we took the poster session and we selected a number of posters, and we brought together researchers and clinicians and advocates into very small groups to learn from each other and talk about posters. The poster itself was not the biggest learning of GRASP. The biggest learning was the importance of connections and of learning from patients. So we really are unique in that we highlight the patient expertise as another expertise in this whole system. So you have the scientist that knows the science, the clinician that knows how to treat patients, but the patients know what it feels like to live with the disease. And what we're doing here today is we are taking this GRASP model to highlight the experiences of Black women living with cancer and how they go through as a cancer patient, how that is a very unique experience. So at the bottom, you see the top pictures are our GRASP exchanges at the symposium in San Antonio. The two bottom pictures are Mayma Carmel when she was 31, when she was diagnosed with triple-negative breast cancer with her daughter Noelle. I mean, these are the stories that women will bring into the conversation, and how were the interactions that they had with their healthcare providers. And this can be, we want to make it as comfortable as possible to have the uncomfortable conversation. That's why we're keeping the group small. These women are really experts in not only their disease, but in the communities that they live in. And they are here giving us their time to teach us to really look inside our privilege and allow us to better treat those of you that are physicians and better interact with Black women with cancer, because that's a unique experience. Thank you, Shonda.
Thank you, Julia. And now, and thank you for, thank you for all that you are doing and for today. Yes, let's do this. Okay, now we're going to hear from Dr. Arnethea Sutton, who has a PhD, and she is from Virginia. She's currently working at Virginia Commonwealth University's Massey Cancer Center, who will give a keynote. So I'm going to stop sharing my screen, and Dr. Sutton, the stage is yours.
All right, good morning, everyone. So thank you very much for this introduction. I'm very excited to be here today, mainly because of the conversation that we had 2 weeks ago, which really resonated with me and allowed me to put together what I hope is a meaningful and educational presentation for you all today. So we're going to discuss biases in clinical and healthcare professional practices. And one reason why I'm honored to be able to give this talk is because much of the work that I've done and with my collaborators and my mentors look at some of the very topics that we're going to discuss and that their patient experts are going to discuss in their breakout rooms. And so I'm hoping that this will provide a nice foundation for everyone as they have those very necessary but uncomfortable maybe discussions. So I have two quotes here to share, and this one of them I heard on my own. Another, a student brought to me that she heard, and so this one I didn't tell them about the trial because I figured they wouldn't understand it anyway. And this quote was from a white attending physician talking about a Black cancer patient, and they very just explicitly just stated that they didn't do it because they felt that they wouldn't understand it. Also, a medical student, oh, you're one of those people who actually believes in health disparities. So to know that we entrust our care and our health to individuals who pledge and take an oath to do no harm and to provide us care, that these are some of the statements and interactions that they're having with people. And this is not just something that they're keeping inside, but they're actually sharing it openly. This is very dangerous. And this is, I feel, why we are here today, to try to mitigate or eliminate these issues. So what is bias? So of course I decided to look it up, and so it can be a verb or a noun. And so as a verb is to give a settled and often prejudiced outlook to something, or as a noun, so having a bias is a personal and sometimes unreasoned judgment. But recently we've been hearing the term implicit bias. And so implicit bias is supposedly unconscious, learned stereotypes, and unintentional. And 2 weeks ago, when we started having when we had our first discussion, one of the things that I said is, you know, we do use these terms exist, implicit bias is certainly real, but I challenge all of us to move more toward the maybe more uncomfortable but real term, which is racism. If you look, remember the implicit bias said is unconscious, which racism can be both conscious and unconscious. We believe that racism is, yes, learned, is drenched in stereotypes. And so today I challenge you all to keep that in the back of your mind. I always say that I feel that terms like implicit bias are almost like feel-good terms to make you feel okay with what you're doing, because it sounds quite passive. But we know that the impact of implicit bias, the impact of racism, of microaggressions, they can be fatal. And so this is why I have Let's Call a Thing, and why we're going to try to attack this very thing. So I started with trying to understand implicit bias a little bit more, and I'm going to present to you all some research studies that have looked at this. And so one was a systematic review. And so a systematic review, researchers go and they look at all the studies that's ever been published on one topic. So this particular study here was published. They looked at articles between May of 2015 and September of 16. They found 37 studies that talked about implicit bias. 31 out of 37 of those studies, the individuals that they researched had a pro-white bias. And specifically in the study, they said these individuals had a pro-white or pro-light skin bias, an anti-Black, Hispanic, or dark skin bias. That's 31 out of 37 of those studies. And these, let me add, are about healthcare professionals. Amongst the studies that observed a relationship between implicit bias and outcomes, 43% found higher implicit bias that it meant disparities in treatment recommendation, empathy, and pain management. And I'm gonna talk about that in a moment in a few slides. Interestingly though, 100% of the studies that assessed implicit bias and patient-provider interactions found that stronger implicit bias was directly related to poorer patient-provider communication. So herein lies the problem. We have this thing called implicit bias. There are ways to measure it, but what we're finding is that individuals that have that strong implicit bias, which I said is typically to me like the passive term, they are demonstrating poorer provider communication with regard to their patients. Now, this study here is one of my favorite studies to reference whenever we're talking about it, and I have seen it pop up recently. So this study was on racial bias and pain assessment and treatment. This one was done at University of Virginia, which is only about 45 minutes away from me. And they wanted to understand what the impact of implicit bias would be. So they did two small studies within one. The first study they did was with white community members, so non-medical individuals. And they asked these individuals to rate what their pain on a scale of 1 to 10, rate what their pain would be if they like closed their finger in a car door, stuff like that. And then they asked them to assess some beliefs, some biological beliefs between Black and white people. Some of them were real and some of them were not. And some of them that were more false were, oh, Black people have thicker skin. Black people do not experience pain the same way as white people. And so they rated those. What they found with the non-medical white individuals was that individuals that had higher beliefs, of higher false beliefs, so most of the false biological beliefs they believed, they rated a white person's pain higher than a Black person's pain. So they said, okay, if I close my finger in the car door, I will rate my pain as a 9. And then later they gave them a scenario, oh, a Black patient presents and they close their finger in the car door, what would their pain be? And they would say like a 4 or a 3. So then they did this same study on medical students. These were medical students at the University of Virginia, and this is what they found. So this one looks at the recommending accurate treatment. And they found that medical students who rated higher false beliefs were more likely to recommend accurate treatment for white patients, way more, significantly more than for Black patients. So less accurate treatment for Black patients for these individuals who had these false beliefs. So we see here, non-medical individuals, medical students. And so why we're here today is to figure out, how do we fix this issue? Another study that's a little bit closer to home to what we're discussing today with regard to breast cancer was on genetic counselors. So they looked at genetic counselors' implicit racial attitudes. They took patient simulated, like people who acted as patients, and they interacted with genetic counselors. And ultimately what these charts on the right show you is that the bolded ones are the significant differences. What they found were significant differences with regard to like white clients. They rated lower, significantly lower for verbal dominance. So they don't feel that the counselor was super dominant with them with regard to verbal interactions when compared to the Black clients. But if you look down, Black clients rated, Black patients rated way lower for positive global affect. So they didn't feel the positive emotion that the white patients felt. And so this was a good example here of individuals just interacting with their patients, genetic counselors, on these topics, and going back and finding out how patients felt about them, and seeing here that there are very clear differences in how white patients felt than what Black patients felt. So why does all of this matter? Why are we here? Why does implicit bias matter? So health disparity, and I never take it for granted that everyone understands or knows what a health disparity was, especially given that quote that I gave you initially. So health disparity, higher burden of illness, injury, disability, or mortality experienced by one group relative to another. And in the wake of COVID, I'm sure everyone has heard this term because this COVID has highlighted health disparities. As a matter of fact, my mom told me when she was watching the news about COVID back in like March and April, she was like, oh man, all I'm hearing about is health disparities. You were the only person I've ever heard talk about health disparities before. And I would like to think I was at the forefront of this field, but I absolutely was not. But now we're all more so aware of this. So let's talk about breast cancer disparities. So these figures that I'm going to show you are all from the American Cancer Society Facts and Figures. I like them because they're easy to read and comprehend, and they're readily available online. So this shows you age-specific breast cancer incidence by race. And, you know, years ago, you know, breast cancer was perceived as a white woman's disease. The incidence rates for white women were typically higher than for Black women. As you can see, within the last couple of years, those numbers have started to converge a little bit, and you can see that varies with regard to age. But generally speaking, the incidence rates for white women tend to be a little higher than for Black women. When we start breaking it down, though, we're going to talk about disparities. We look at the distribution of subtypes. As you can see what I have circled here. So amongst Black women with breast cancer, approximately 20% of those are triple negative breast cancer, which is a more aggressive breast cancer. If you look across the other races, you can see 10%, 12%, and so forth. By stage, if we look at differences in stage by race, we see that Black women are more likely to have regional or distant or metastatic with regard to other races. And then for mortality, we know that Black women are 40% more likely to die of breast cancer. But if we look at these 5-year survival rates across stages and broken down by race, every single stage, we see that Black women have a lower 5-year survival compared to all other races and ethnicities. So when we're talking about breast cancer disparities, these are the larger outcomes that we're talking about. But then the question lies in how have we gotten here, and how does implicit bias play a role in this? So I kind of broke this down a little bit, how biases impact Black women across the cancer spectrum. And I'm a strong believer that it impacts prior to, upon diagnosis, during treatment, and post-treatment. And as you can see here, I have in the arrows some of the disparities that we see with regard to Black women. And then some of the, we know there are disparities in genetic counseling and testing. We know that there tend to be more delayed diagnosis with regard to Black women. And, you know, I've heard stories from even some of my friends who were diagnosed. I'm sure you all have heard stories too, about Black women knowing that something was not right with them and going to a healthcare provider and having to go to multiple providers until they're finally diagnosed with breast cancer. Then once you get there, sometimes there's surgical delays. So Black women seem to show a longer time from diagnosis to surgery, issues with treatment initiation, adherence. So adherence to therapy. We think about women that are diagnosed with hormone receptive breast cancer. They're prescribed adjuvant endocrine therapy, which they can be on for up to 10 years. And we're starting to see now that adherence rates for Black women are lower than for white women, and that's problematic. And then lastly, we have treatment-related toxicities, which is an emerging field, and we're starting to look into that. And so it's like, how are your treatments impacting you? What side effects and symptoms are you having? And are those being addressed and cared for? So we're going to look at one of these in particular. So this is prior to and upon diagnosis, and I do a little work in genetic counseling and testing. Now, just briefly, for those of you who may not be aware of it, genetic counselors can provide information about your risk of cancer. So individuals that are diagnosed with cancer, they can go there to help them with treatment recommendations, but family members may also go to understand what their risks are. And so we see here that Black women are less likely to seek genetic counseling and testing when compared to their white counterparts. Studies show that Black women are less likely to be referred to counseling. So their providers are less likely to even refer them. But a study that I published last year and other studies have shown that once they're referred, there are no disparities in uptake. So then what's the issue? If you're saying then that the disparity is in the referral, then herein is an interaction problem. So why aren't physicians referring Black women to the same extent that they're referring Black women? And then once they're referred, we realize that there are no more racial disparities. So they're seeking counseling on the same level. When we had our first discussion 2 weeks ago, I briefly mentioned focus groups that I did with some Black women, some who did not have counseling, some who did, all who were at risk of hereditary breast and ovarian cancer. And I pulled some of these quotes from my focus groups. One, I think the doctor should provide information when you go for it. I brought it to my doctor. So women feeling like they have to bring information to their doctor because their doctor is not giving them all the information. I think knowledge is the key once you are informed. You have some information and you can fight better when you go to your doctor. I don't know about you, but the last term that I want to think about with regard to going to a healthcare professional is fighting. And yet Black women feel that we have to be prepared, equipped, knowledgeable, have all the resources in order to get the care that our providers should just be providing to us. Lastly, well, mine was not having Medicaid and not being able to pay for my own treatment. I guess the doctors never decided to say, hey, this is how much it's going to cost. Would you be able to come up with the money? They just say, you know, hey, she's probably on Medicaid. She's not going to be able to go. So yeah, that was that woman's perception. But perception, I always believe your perception is your reality. And this is her reason for believing that her provider did not refer her to counseling or even tell her about it. So frequent contributors to disparity. So of course we can't talk about disparities without talking about social determinants of health. And social determinants of health are those that I have listed, some of those that I have listed here: your education, your occupation, your income, access to care, your geography or where they live. But we know that social determinants of health are absolutely influenced by racism. We're going to talk about some of the studies that I've done, and we've already mentioned some of these prior to my discussion today. So medical mistrust is a topic I love to discuss. And about a year or two ago, I published this paper here looking at medical mistrust in Black breast cancer patients. So in this study, we had 210, well, let me give you an overview. This study was a study of breast cancer patients overall. So we had Black and white women. We found with medical mistrust that Black women reported significantly higher mistrust than white women. So I decided to utilize those data to look at what was driving Black women's mistrust. So I had 210 Black women in this sample, and medical mistrust. So women that reported higher medical mistrust reported poor communication with their provider on topics regarding radiation, reported poor satisfaction with the technical and professional quality of their healthcare professional. The similar vein, I also looked at women's suspicion of healthcare practice. And so women with higher suspicion of their healthcare reported poor communication with regard to chemotherapy and less satisfaction with the interpersonal behavior of their provider. So if you look at what those mean, that means that if the provider is supposed to be talking to women about these life-saving treatments, but women have these perceptions or these realities of, I feel mistrust, I have suspense or suspicious of you, then how are we supposed to really navigate women or make them feel comfortable to receive the treatments that we're saying are life-saving treatments? The next is discrimination. And so earlier this year, I did a study looking at discrimination that's reported by Black and white women diagnosed with breast cancer. So in this study, this was the entire 359 women, so Black and white, 58% of our women were Black. So in most studies looking at discrimination, a majority of people do not report any kind of, this was racial healthcare discrimination. So a majority did not, but of the women that did, 47.1% of Black women did, 16.2% of white women did, and that was a statistically significant difference. What's interesting is that 63.4% of women that reported discrimination said their race was the reason their doctor or nurse did not listen to them. So they went in, they felt they weren't being listened to, and the first thing they thought of, oh, they're not listening to me because of my race. When we did some further analysis for Black women only, we found that Black women reporting discrimination was directly related to trust in provider. So women who had less trust in their provider tended to report issues of racial healthcare discrimination. And lastly, this problem with communication. So as you can see with the studies that I've reported already, communication is a big problem. And so some of my collaborators published this study looking at the initiation of adjuvant endocrine therapy, because as I already said, there are some differences there with regard to race. And they looked at 270 women. All these women, of course, were HR positive, and 55.6% of our sample were Black. We did note that there was the lowest initiation was actually among Black women that were less than or equal to 50 years of age. And actually, the highest initiation was among Black women over 50. What's really, what we need to pay attention to though, is we know that Black women tend to be diagnosed with breast cancer at younger ages. And so for this to be the group that had the lowest initiation, then we know that that is a group that we need to focus on. The factors that were associated with initiation though, were financial access, which is one of, we talk about social determinants, comorbidities, and once again, communication. So poor communication with your provider may determine whether or not you initiate therapy or initiate it on time. So where do we go from here? Like, you know, Mayma said best the other day, and it really resonated with me. Like, we talk about these problems, and it's like, now what are we going to do? How are we going to solve them? So one is, and all these I'm sure you've seen recently, especially in the media, so implicit bias training. We've seen a lot of organizations and healthcare, health centers and academic centers initiating or starting implicit bias training. So I did some reading up on some to find out like what is the outcomes been of some of these trainings. And so the findings are mixed. Some people say, some studies have shown that, oh, you know, we did a pre-test, we did the training, we did a post-test, and we see good differences, okay? Others have shown that they did a pre-test, then they did some training, post-test, great changes, and then they did a test further down the line and things kind of went back to where they were before the training. So now our focus is how do we deliver great training that's going to give us the impact and the outcomes that we need to actually move the needle. Places are now starting to, organizations are now starting to look at chief equity and diversity officers, because one thing we know within the healthcare field, especially with regard to Black women and cancer, a majority of your providers, a majority of your interactions are racially discordant, which means that most of your providers do not look like you. And so what do we do about that? How do we increase diversity in healthcare? And so we are hiring chief equity and diversity officers to look at this. The next bullet, diversify pipeline. We do need to increase the number of Black and other minority students that are going through the pipeline that are going to end up being our scientists, our researchers, our clinicians. Provider level intervention. Some would argue that these are sometimes the most difficult because intervening with doctors is quite difficult. But there are studies out there that are doing this, that are looking at ways to do interventions with doctors with regard to how they communicate and interact with their patients. One particular that I'm aware of is what's happening at Virginia Commonwealth University, where I am, where they're looking at how physicians interact with patients with regard to clinical trials. And then patient level interventions, which seem to be, more people lean more toward those than the provider level interventions. And so I have an opportunity now to highlight one of the interventions that we're doing in the lab that I work for. It's Sisters Informing Sisters. It's a study that was just recently funded by the American Cancer Society for 5 years. And this study, I love it. It's a randomized trial that's looking to improve patient-provided communication, patient-centered care, which means that we're the physicians focusing on the needs, values, and preferences of their patient, and ultimately to improve treatment adherence in Black women newly diagnosed with breast cancer. And so my mentor, Dr. Vanessa Shepard, piloted this when she was in Washington, D.C., moved to Richmond, now has funding to launch the randomized trial. And so she, along with some of her patient experts that she's been working with for years, have developed these training guides. So we have a facilitator's guide that's going to go to some survivor coaches, and they're going to be partnered with women who are newly diagnosed to help them as they're going through their treatment, help them with communication and interactions throughout that whole treatment process. And so we're just getting that underway, and I'm really excited, and hopefully we'll have some preliminary data to share within the next year or so. And then lastly, of course, today's discussion. I'm hoping that what we get from today's discussion will be rich. It's going to be uncomfortable. It needs to be to make people feel, feel all their feels, all their other emotions, and what they need to do and how they can make some changes. And so before I end, I like to show these pictures. I'm sure everyone's seen renditions of these pictures, but I like how they've kind of morphed over time. And so typically we see, everyone, like one person on the ground, but I like this reality picture because the truth is that some of us aren't even ground level. Some of us are below the ground. We still have a way to go just to be on ground. And so I think this picture is an accurate reflection of reality as it stands. But as time has gone on, this is where we want to morph into, equality is not enough. Everyone doesn't need an equal share. Some people need a little bit more. And so we do need to see how can we move from the current reality to achieving equity, justice, or even the pictures on the bottom are newer pictures that I've just come across, empowerment and liberation. And so I feel that our discussion today, our ongoing discussion, and the deliverables that result from our discussion today will hopefully move us more towards our equity, justice, and empowerment. And lastly, just some good reads. And so for people who are interested in understanding, medical mistrust and discrimination in healthcare, I suggest some of these. So Medical Apartheid, widely known books. It's a very interesting, it's a very dense read, but a very good read. The Immortal Life of Henrietta Lacks is a wonderful book to understand the cells that were stolen from Miss Lacks and how they have propelled science as we know it. And then a book that actually just came out about 2 or 3 weeks ago. This is called The Organ Thieves, and I'm just about starting this book now. This one it took place here at where I am at VCU, and it's about a Black man that went into the hospital for one thing, ended up dying, and when they checked him, his heart was gone. So they actually used his organ for a white man, but that's not why he went into the hospital whatsoever. And so I can't wait to dive into this book. But I think this gives some context into this idea of racism in healthcare and implicit bias. And so, of course, if anyone has any further questions for me or about anything that I presented today or about the topic of implicit bias and discrimination and racism, please feel free to email me or to follow me on Twitter. Thank you very much.
Wow. That was amazing. Thank you, Dr. Sutton, for such an enriching discussion, conversation. There were so many comments in the chat of people asking even if they could use the slides or share, if you could share the slides afterwards, they can share as well with their communities and their different circles. This is just so powerful. Everyone is just responding and saying thank you for your feedback and for this conversation. And I like the point that you said too about equality isn't where it stops. Like, this is about empowerment, it's about liberation. That's what we really are striving towards. And there's a lot of excitement as well about even the study that you're doing, Sisters Informing Sisters, and where it's going to take us. So I just want to thank you for that comprehensive conversation with data, and also just, you know, their passion that you have towards this topic. It's really important, and we're so grateful to have you here. I think it's definitely has tied in well with our discussion that we had 2 weeks ago about understanding no more disparities, and to your point that unconscious bias is just another word of saying really it's racism. And that's really what it is, and we just need to call a spade, and name them, and then also address this. So thank you so much, Dr. Sutton, for that presentation, and I think it's definitely given a lot of thought for as we move into the breakout rooms. But I'm going to try to share the grid screen so that we can just give her a virtual clap for that presentation. Yes, because it was well done. We are so much better as a result of this, and we're so thankful that you are the first person to kick off our Pull Up a Seat. We couldn't have asked for you know, someone better than just the way that you set the tone for it. Very grateful. So now we're going to switch over into our breakout rooms, and I'm just going to pull up a little bit about the agenda. Let me pull up the agenda again as I share that. I'm going to go back to the agenda actually. Should I pull this up first? Okay, so now we are going to move into our breakout rooms where we're going to have our Black patient experts lead the discussions. We're going to have about, I think, 5 breakout rooms, if I'm correct. I believe that's how many. We have 5 breakout rooms, and so we're going to be placing all the participants that are on this call. The majority of you will be placed into these breakout rooms, and then there will be a main room, which I will be in, and some members of the Tigerlily Foundation, GRASP, and other advocacy groups. Thank you. We'll have 6 breakout groups, and then the advocacy groups that are present will also be in the main room for us to have our own discussion, while the Black patient experts and physicians, non-Black physicians, and healthcare professionals will be in breakout rooms so that we can have that conversation. So just the format within the breakout rooms, again, it's our patient experts, if you can please, you know, share about your story, introduce yourselves, and maybe introduce everyone, you know, who's on the call, except for the note takers, just to sort of say a quick hello as to who you are and where you're coming from. And then if you can share your story and then start the conversation. I think Dr. Sutton has definitely given us food for thought, and I think it's a great point for us, you know, just to have that conversation. So there'll be 25 minutes of conversation. There will be a note takers in each room that will be, you know, just listening and taking notes for that. The breakout rooms will not be recorded, so please feel free to be as honest as you can in that space. It's a safe space. And then, you know, have a sort of a summary towards the last 5 minutes. You will see, we will let you know when there's 5 minutes left, or I think about 30 seconds, there will be a countdown for you to come back into the main room where we'll share what we learned in those breakout rooms. So thank you all for your time. So excited for us to move into this section of the conversation, and just please be patient for the next about like 2 or 3 minutes as we transfer you into the breakout rooms. And
yeah, so the note taker will also keep track of time. She'll let the Black expert know when you have 5 minutes left, 15 minutes left. And then we also wanted to remind anyone that is on their phone or doesn't have their camera on, this is the moment where the conversation is going to get personal. It's going to be small groups. We want people to really connect with each other, feel uncomfortable. The best we can do is virtual. So we do ask everyone to turn on their cameras.
Main room, as you can hear from Lisa's comments, we have also been having a conversation in the main room. Some of our patient advocates have been in here. We've just been talking as well about what role can advocates play and what can we do, and you know, sharing about some of the whistleblower experiences. And we were talking about how we have to the idea of having to protect Black women, protecting this Black nurse who has been a whistleblower for the forced hysterectomies of undocumented women, and then also how can we hold agencies accountable, you know, to that in this process when someone does step forward, because this is something that, you know, it sort of adds on to the idea of mistrust, and how do we sort of change that? And some of the ideas that came about was that we also need to share success stories as well. even, to sort of combat all this mistrust that we were seeing, and sort of getting from our grandparents and the previous generations being like, I told you so, it's the same thing. So that was some of the stuff that we were discussing. So welcome back to the group. And we're going to, take the time to have everyone, each person, each of the Black patient advocates, we would just like for you all to share from each breakout room some of the feedback from that conversation. And when I do ask, I'm going to ask by breakout room number, if you can just say your name and share a little bit about yourself, and then also give us a recap. That would be great. And we'll spotlight your video. So whoever was for breakout room number 1, can you please share or unmute yourself?
Hey Roberta, this is Alicia. I'm just checking on you and just to let you know.
Julia, do you know who was
It's
number?
Sheila.
Okay.
Sheila's number 1.
Oh, that's okay, Sheila. All right, there we go.
Well, I'm Sheila, and I'm a 10-year metastatic breast cancer patient, and I've been living with metastatic breast cancer that has spread to my liver and ribs in 2009. I'm a 25-year Air Force veteran, and my mom, she was diagnosed in 2001 of metastatic breast cancer, and she died in 2004. And, what's always at the back of my mind is, well, why did she live 3 years and I'm living 10 years? Was it the type of medicine? Was she not offered the type of medicines that I had, that I'm on, or just many different things when I was diagnosed? So, that's my passion and the legacy I want to leave, because I never knew what type of breast cancer my mom had. I didn't know that it was triple negative breast cancer or HER2 positive, So that's when I dove into being a patient advocate. And from my group, I just wanted our allies to see that, I'm human, I'm Black, I have feelings, and, I want my doctor to be just as passionate about me as she is, and I think she is wholeheartedly, about white women. And I always tell her, treat me as I'm living, not as I'm dying, because I'm a metastatic breast cancer patient. Treat me as you would stage 0, 1. Don't treat me. And she hasn't, and I say, ask your doctor about clinical trials, and just make sure that you're getting the right resources, that we try to break the barrier, not barrier, but because it's hard. I didn't even really know about Henrietta Lacks until I got breast cancer, Was I dumb? Was I, I just didn't know, and I had to read up on Tuskegee only because I went to a school down there, a military school down there. So just make sure you read up on the information. That's the kind of things that would be discussed in our group. Make sure that you have that great patient-doctor relationship. And not all of us going to have, because there still are racial biases. And they say this, we should get into the medical schools and let the medical students see Black women that were human, and that we want the same type of treatment that our white counterparts get, and that we want to bring that 42% down as much as we can. That should be our maybe 5-year goal, is how can we do this collectively with everybody to bring that, because I've been an advocate since 2013 and it's still been 42%. So what are we doing wrong? But I thank the women and men in our group, and thanks for listening, and thanks for sharing your ideas.
Thank you, Sheila. Thank you for sharing as well, and for leading that conversation in your breakout group. It's really appreciated, and this is a part of hopefully continuing to move the needle forward. So we're going to move to breakout room number 2 with Jamil. If you can give a recap about what you guys discussed.
Yeah, so I think we went through, we didn't have to really go over that there are disparities. We know that, right? But what can we do about it now? I shared some of my personal experiences. And then also with the work and advocacy that I'm doing and some of the different stories and examples there. And, I think really at this point, we can talk about, we can't, in my opinion, we can't train racism away. But, I look at it where, you don't have to like me. You don't even have to, agree about all hands on deck, but I do will hold you accountable and you should respect me. And so I try to push for other Black women that are impacted by breast cancer or diagnosed with breast cancer or living with metastatic breast cancer to do the same. And so in my professional life, I'm a nonprofit CFO, so I always think about the money. And so I'm always like, follow the money. So I feel like, we don't have to train racism away, but if you want those dollars, if you want that NCI designation, if you want the appropriation, or if you want that grant funding, or if you want that policy funding that's coming through, the same way that we have, accountability when it comes to integrative therapies and support resources and all of that, we should have health equity plans that are demonstrated and accountable as well. And so that's what I continue to push for. I think we're at that point. I think we have so many research studies that demonstrate, what are these contributing factors and what we need to do about it. It's not a mystery. I think that the same way that we know that younger women have different unique challenges with breast cancer, and, different subtypes should be treated differently. It's the same thing for Black breast cancer. Black women should be, treated as a high risk group with their own unique, personalized, concise plan to treat their breast cancer. And I think that's really where we need to go now. It should be personalized. Cancer centers and teams should know that, okay, I have a Black patient here. Let's make sure that at least the access and treatment is equal, that there aren't any treatment delays or diagnostic workup delays, that all the barriers are addressed. Once that is factored in, I don't think that you can pull out bias. It's going to be there, but if there are accountability measures where there's visibility, it's going to be much harder for your racism to impact me as a patient. Because there is visibility, there is sunshine on that, there is data, there is reporting, and there's accountability. And so I think that's where we are now. And then also just as not just in the breast cancer treatment realm, but when we're thinking about survivorship and living with metastatic breast cancer, what are those support resources, how to stay people in care where they're not impacted by the lack of support when it comes to getting that support after that initial treatment. Because what's interesting now, especially in metropolitan areas, a lot of the treatment is equal, so it's when after you get outside of that where the support gaps start coming into play, or the societal and structural social issues start impacting our ability to keep on that continuum of care once we've gone through that initial treatment. So insurance doesn't necessarily always mean access. We definitely talked about that. And, I think we have to start getting away from those traditional assumptions that, Black women are poor, or, Black people don't, like even at social economic levels, you can still be impacted by, disparities or racism. So it doesn't necessarily have to be like, oh, she can't afford that genomic testing. You don't know what what I have in my pocket. So getting those traditional narratives and tropes out the way, where it literally is thinking about what support resources can we provide to make sure that this Black woman has the best care, right? Stays on the care and gets the care that she needs. And then understanding that we're going to have different side effects. We have a different framework at home where our support system and structure has to be a little bit different, right? And so just not feeling like a trickle-down effect is going to work, and that, it's a personalized system in place for our care, the same way that we can do it for young women, the same way we can do it for older women, the same way with men, the same way with different subtypes. Let's have a specific targeted, personalized care for Black women. And it's really about that time. We have the data, let's get it done. And you know, so that's what we talked about. And it was really great to hear about the initiatives that they have going on in order to address these issues. And I think we talked about valuing Black women, right? Hashtag say her name, $12 million settlement for Breonna Taylor. You know, everyone loves Michelle Obama. I think society is starting to accept that Black women have value. And so even if it's not something personalized within that gatekeeper, that medical professional, we can still hold you accountable to that, right? We can still have systems in place to make sure that we're not falling through the cracks. And so I think that's the point where we are now, where we just have to have that accountability in place. And let's advocate for that to be in a structured way where, you know, my life is not contingent on someone believing whether or not if I'm deserving of that care, right? And they're functioning as that gatekeeper. And so that's what we want to get away from, where it's so contingent on the racism from this person that they don't even know whether or not if they value my life or not. But we have a lot of these systems in place where it's not all hands on deck for Black women. And that's what we need to change.
Indeed. Thank you. Thank you, Jamil, for your comments. Someone wrote Jamil for president in the chat. Yes, people don't know what's in your pocket and they need to treat you as a human, period. Like it shouldn't matter what's in your pocket. You deserve equal opportunity. And to your point too about personalized care for Black women, the side effects are different, you know, when it comes to survivorship and afterwards. Our community structure is different. So how can you understand that structure and how it impacts our support systems? What structures we have in place after, you know, after the initial treatment. So thank you for that and for your suggestions and the recommendations from that group. I'm going to shift the agenda just a little bit, tweak the order, just because Shonte is in breakout group number 6, but she does have to leave. So I'm just asking for those other groups to be patient so we can have Shonte speak and just share from her group. And then we'll get back to group number 3. So Shonte, please, if you can go ahead and just share from your group.
Hi, everyone. I think my breakout group, we were awesome. We kind of touched on a lot of things, you know, me as a provider and as a patient, and my personal experience as a patient, and my personal experience, especially with racism, as even a provider, and even the lack of access. You know, I work in the underserved, I'm from the underserved, I'm from Washington, D.C. My goal was to always to help my people, you know, and so I still work in that area. Of course, I moved around because I'm military, and I saw the differences in each state that I've lived. And some had more racial notes than others, and I received diverse care from different providers, but almost underliningly, it's all been kind of the same. And even with my medical background, I was denied or delayed certain things. I was symptomatic since I was 25, and I got diagnosed at 36. I'm 31 and I'm 36 now, still living with MBC, but I was always thinking in the back of my head, could I have gotten diagnosed earlier because of all the symptoms I've had? We also discussed like a real reality of the communities that we live in. You know, there are plasma centers everywhere in the underserved areas, but not in the privileged counties where I live. There is not one. And what those plasma centers are doing is collecting information, collecting plasma, compensating the people in the area, and then what they're doing now is trying to cure COVID with plasma. So now the plasma that we've donated is going to the privileged communities, and we won't get that because our insurance won't authorize it, and we won't even probably be aware of it. And so those little dynamics and those type of policies, and we discussed history, you know, the pseudoscience of eugenics and all that came with it, and why the mindset is even there. And just like continuity of care, diversity programs, calling it what it is, medical racism, not being complacent, you know, check your colleague, and just, you know, interventions that we could do that's actionable. and changing the percentage of deaths within the Black community and just clinical trials. So, I mean, we kind of touched everything, and I think it was a good conversation with us, and we learned from one another. And if anything, I think it definitely sparked change. Thanks to everyone.
Thank you, Shonte, and thank you for leading that conversation and for being here and for sharing that perspective as well, since you are in the healthcare space and you're also going through this as a patient, you know, sharing that dynamic, the duality of both of those experiences. And to your point, I thought you really brought up a great point about the plasma centers and how they are collecting it from the communities, but they aren't being brought back into the communities, and some of the challenges as well of insurance and how that prevents people within our community from having access to these treatments when it's right. It could be right up the street from them, but they just can't afford it. It isn't a part of their the plan. So thank you so much for being here and for your voice and your story and for sharing space. We really appreciate it. So
I'm honored.
Thank you. Okay, so now we're going to move to group number 3, who is Jersey. Jersey, if you can share about your group, please.
Hi, am I on mute? Can you hear me?
Yeah, we can hear you.
Hi, I'm Jersey. I am the founder of Angel in Disguise. I'm one of the voices behind the Inclusion Pledge. I like to say that because that means that Jersey doesn't back down from a fight. And so what we discussed was about my recent experience with palliative care. I've been metastatic since 2011, and just this month, after complaining about pain, I was referred to palliative care, and I was referred like the beginning of September, and I didn't get an appointment till yesterday. And my first response was like, "What the hell? Like, I'm metastatic since 2011, and you're just now telling me to go to palliative care for my issues." And then I'm like, I see my doctor next week, so she'll hear an earful, but I'm just like, did my Black not matter? Like, my pain, was it not important to you that I should have gotten palliative care, or was me being in the bed for 3 days at a time okay with you? So, you know, we really addressed that, and how 45% of white people, they hear about palliative care, only to 35% Black, and white people often request palliative care. And we also talked about, like, because people think palliative care, they think like, oh, it's the end of life. So these are different terms that when you're first diagnosed with cancer, just mention these terms, like these are different resources that you may have to go to one day. Not everyone may need these resources, but if you introduce these terms early, then it takes out the mistrust. It doesn't feel like the doctor's giving up on them. It doesn't make you feel like you're suffering in silence. Introduce palliative care, introduce different resources that we can go to. Just things that we don't know about. Don't think because I'm Black and I live in this community, maybe I don't have transportation, but I may not have transportation for various reasons. It doesn't mean I'm poor and I'm uneducated and I don't deserve the best treatment. So those are things that we really talked about, just having different resources and introducing different words into our vocabulary, as well as giving us things to read, because of course, you know, as cancer patients, we'll forget that information when we go home, but like these things are very important. And yesterday I was introduced to a social worker for the first time. Like, you didn't think I needed a social worker? My mouth is big, and yes, I advocate for myself, but these are things that, I mean, mentally, I would like a social worker so I can have someone just to talk to or tell them stuff. So I was just introduced to a social worker. So these are things that if we don't know these things, then we don't know to ask them. So it's very important. And I'm also a big advocate about Black people in healthcare being visible. So like I always say, if you're doing a commercial on breast cancer, I need to see someone that looks like me so I can pay attention, and so I could to know what to ask, or so I could say, oh, there's a new drug. And if you only show white people with this drug, then as Sheila would say, I didn't know Black women could get breast cancer, or I didn't know that drug was for me, because you're showing it for white women. So Black people can't use that drug. So if you have us in the conversation, if you make us visible, it makes a big difference. You know, it makes the conversation a little bit less uncomfortable. And and my last thing I would like to say is, you know, with all the doctors and scientists and research and everything, and I say this as a Black woman, I say, stop pimping us and start partnering with us.
And that's that on that. Stop pimping us and start partnering with us. I was writing that in the comments. Partnering with us. Okay. Thank you, Jersey, for sharing. And, you know, you always coming through with those catchphrases, girl. You just have them on lock. Thank you so much, though, for sharing. And just, you know, it takes a lot even to be able to share that, the experience, because this is your life. This is what you're dealing with. This isn't, you know, this is your reality. And people need to understand that. And it needs to change. It needs to be different. It can't be this way that after all this time, you're just seeing a social worker. And you, like you said, you're outspoken, you know, and even for you, you're still dealing with this. So thank you for that. Thank you for sharing.
And one more thing, I told my group, my oncologist has met Angela. Next week, she's going to meet Jersey.
Oh, there's a difference. Yes. Yeah, so all right, so we're going to move on to Roberta. If you can please share from your group 4. Thank you. And thank you, Jersey.
Hi. 2 weeks ago, I shared about what I was going through with my own medical issues, but that wasn't what I was going to talk about. I was going to talk about as advocates and patients that we should, if we don't like our medical team, that we should fire them and get someone new who's going to listen to everything that you have to say. Then I dove in about what I'm going through now. And I'm not going to make some of the comments that I made in the group, but at the end of the day, the medical profession need to not assume that people know what's going on. They need to build trust, build relationship, and have that conversation and let the patient know what it is that's going on with them and let them decide what to do and what not to do. So with me, I have to go through all these tests now, and we're talking about being in a pandemic that I have to go in for surgery. And that I'm not too thrilled about, especially if I can't have no one go in with me. But more importantly, with regards to clinical trials, the medical community need to offer that, not assume, as it was spoke on in the previous conversation, that Black people can't afford this, that, or the other, or more importantly, stop talking about Black people being poor and why they can't afford, because I'm dealing with a patient who's educated, and I consider myself educated, but yet we still fall into that disparity issue that we're having now. And more importantly, we as advocates, we need to change the narrative with regards to the medical community. We need to see if we can stop having the medical community telling patients, especially early stages, that they're cancer free, and then years later, their cancer come back and they feel as though the medical community use them as guinea pigs. So I'm dealing with a patient trying to get her to take some medication, and she refused to do it because she feels as though the medical community lied to her back in 2016. Here it is 2020, she's diagnosed again, but she won't take the medicine that she needs to help her. And with clinical trials, Black people feel as though we're guinea pigs. So at the end of the day, we need to build a relationship and trust with Black and brown people. If we don't do that, we're going to continue to have the problems that we're having now. And more importantly, like I said in my group, would you tell your white woman and white men, I want the same thing. But more importantly, my life is just as valuable as theirs. And don't tell a patient that your issue is not important.
That's it. Don't tell a patient that their issue isn't important. Every single issue, everything that you raise is important. Thank you for that, Roberta. And your life is just as valuable as theirs. It has been, I mean, you know, even years, hundreds of years or previous, when we were told that Black people were only three-fourths of a percent human, three-fourths of a human. And to this day, 2020, we're still dealing with that residual effect of being seen as less than human. So thank you for that, Roberta. Thank you for sharing. And I'm gonna ask Nunny if you can please share about your group, and then we'll wrap it up. Thank you. We're gonna go over probably about 10 minutes. So thank you for everyone's time, and to be mindful of that, we'll just be about 10 minutes over. But Nunny, please go ahead.
Hello, I'm Nunny, and I was diagnosed in 2017 with MDC. And actually, a lot of the things that the women already spoke on, some of the things that we talked about in my group as well. One of the things that we also talked about was the lack of support sometimes that Black women, they feel they don't have. And, I kind of went over my experience that I was dealing with the palliative care, about how the physician was pretty much sold on giving me a treatment that I didn't agree with. And I felt like it was because of, how it looked, because I work in pain management. That particular medication we used to give to patients to come off of street drugs. So I know how all that worked, but when I walked into that room, I was treated as if I didn't know, I wasn't educated, and that experience was just devastating, and it opened up eyes. And so I felt like, I shouldn't have to worry about getting up in the morning, putting on a three-piece suit or something like that, just to go to see my provider so I could look a certain way, so you could treat me a certain way. When I go to my provider, I should worry about my care. I shouldn't have to worry about me having to research and bring the information to you. You should have this information that you bring it to me. And a lot of times when I was taught to some of the women that I would meet, white women, they would tell the same type of cancer, they would tell me the treatment plan, how the provider work with them. I was like, I didn't get that, or why wasn't I told about this? And, why wasn't this shared with me? And then I having to go to my provider, share this with them, and it's almost like, oh, okay, she's not dumb. She is educated. About the fact that when they're in school, what have they been taught about this situation? Like you said earlier, that's something that can't be trained on. And I asked, pretty much how do they feel about that? And one of the things that was mentioned was communication, being open and honest, and holding people accountable. If you're in a situation, something happens, sometimes you just have to call people out, because the only way they're going to know is you call them out. You have to use your voice. You keep letting things slide by and not talking about it, it's never going to get fixed. So sometimes you have to put yourself in that situation, whether it's uncomfortable or not, and just call them out. That's what I do. And because at the end of the day, I pretty much hired you to take care of me. We talked about the trust issue as well. And we talked about, insurance. That's something that don't get talked about. And with me working in the medical field, I have seen so many, things behind the scenes where a patient would come in with a certain type of Medicaid, and in my community, majority of it is Black, and it's like, oh, okay, we're just going to give them this, or we're just going to do this. No, you should treat. When you took an oath, to treat patients. You should treat patients based on their care, not because of their insurance. Sometimes, yeah, you may have to step aside and be like, do a little extra, but that's how you get paid. That's how you get patients to trust you too, to let them know that you care. So we talked about that. And also talked about just some of the things that I was able to ask like some of my white friends that I have met, some of the experience that they have. And as providers, they was also able to share, you know, how they felt when a patient walked in and automatically thought that they was going to treat them a certain way based off their race. So they wanted to know how to get over that. So yeah, so that's basically pretty much what we talked about.
Thank you for that. And thank you so much for sharing about your story and your unfortunate experiences. Like I said before, the purple hair is definitely a and everyone can pull it off, but you can. And yeah, it should, you know, in the comments, we were talking about the same thing about how we also need to have insurance companies in this conversation as well, and the importance of them being here. You know, just I want to thank all of you for each of one of you for your expertise and the experiences that you have shared. And hopefully that this, by sharing these stories and also discussing them with healthcare providers, those who were on the call, that you know this has an impact and a lasting impact as we continue to move forward. I wanted to, for the sake of time as well, I wanted to also just share my screen. I want to show, ask Sheila if you can just briefly to share so about our upcoming brochure. So this brochure is going to it's going to also, just from the feedback that we've been receiving in the comments, this is going to, you know, come into an artifact that we'll be able to share. But this is the initial step, and the starting point of it was created by Sheila McGlown. So I'm just going to share the screen. This is a rough draft, but I wanted for you all to see what we're working on. Okay. Let me just make it larger. Hold on one second. Minimize, okay. Come on, present. Okay, all right, Sheila. So I know this is also your second time seeing this, but just, you know, to just share a little bit about what, why you started this, and you know, what your intention, you know, what we hope to get out of it. But go ahead.
I just thought that this would be something to give to medical professionals about Black women. My thought process was they don't know what they don't know. Do they know, or are they ignoring it? Or so I thought that patients could either we disseminate this to all hospitals, or have patients bring this in when they're being seen to their medical professionals. So I wanted to give oncologists and researchers and doctors some statistics about African-American women, which they probably know. I don't know what they know. And like, what can they do to break down these barriers? Like, what questions they can ask as far as like transportation and different things like that. Do you have family support? What are your fears about a clinical trial? Have you heard of a clinical trial? Just different things like that. So I just came up and I brought it to Tigerlily, Mayma, and Shonte, and they liked the idea, and hopefully it will garner some positive feedback from oncologists to say, hey, well, maybe I didn't look at it this way, and they can, you know, to start treating us as, you know, they do with their white patients. So even some, as far as financial toxicity, you know, like I was telling my group, you know, I'm in a clinical trial. Monday, I was there for 9 hours and 28 minutes. But how many women, and, you know, young women can be on a clinical trial to do that? So we have to, those are some of the things that we have to consider. Or do you even know about the Tuskegee Airmen Project when you're talking to a Black woman about clinical trials? Or do you know about Henrietta Lacks? Because I said in my group, I didn't know about Henrietta Lacks. Was I stupid? I don't know. I was just living in my military dream world. And then my mom died of it, and I just, you know, 5 years later, I got it. So it's just so much information all at one time. To not only see your mom die from it that had spread to her lungs, so I'm just like, well, what can we do? Did she get the same type of treatment? Was I supposed to be in the treatment room with her? Was I supposed to be in the doctor's office with her? So these are just some questions. And if you see more questions that we need to ask, of course we can add them. Some questions that maybe we can ask our physicians or our physicians can ask us. So I thought this was very important, and it's a little pet project of mine, and hopefully it'll garner some conversation.
Thank you so much, Sheila. And you're getting such great feedback in the comments in the chat of people just so excited about this and how important it is, and everyone wants to share it. So we will let you all know, and like we said too, some of the conversations that we're having, please feel free to share that with us, and you'll see our email address and stuff later on. But so we can make this, even stronger. This is Sheila's baby, and we just are here to help to bring it to light. So I wanted to share that with you guys. And so, all right. So just parting, as we part and wrap up, I wanted to share my strategy with those who are on the call, which is adopted from the NOVA Collective. And it's something that you can take with you for your conversations. So MICE is to measure your approach, slow down, take your time with the decisions, and consider how your biases might be influencing you. Identify your narrative. Scan the social identity groups and your membership. C, challenge your lens. What assumptions are you making based on that membership? And E, expand your reference points. Work regularly to introduce counter narratives. Consume media, seek out information, and hold space, especially in groups where you are the dominant narrative, i.e., you're white, your narrative is the white one. So that, I would just like to thank you all for being a part of this. Please follow our panelists on social media. Thank you to Dr. Sutton for your presentation. And like I mentioned, a lot of people said that they would love to see the slides and have copies of that. So based off of your agreement, we will share, would like to share some of your slides with the rest of the group. And thank you to Sheila McGlown, to Roberta Albany, Jamil Rivers, Nunny, Reece, Jersey Baker, and Shonte Drakeford for your presence and being able to lead these conversations. And thank you to all the attendees. This wouldn't have been possible if we couldn't have had a conversation, and that goes both ways. So thank you all. We are going to have additional talks. This is the first one, our Pull Up a Seat. The next one will be in October. So look out for that on our social media pages, and everyone who registered, you will be added to our newsletter so you can be able to find out when the next call will be. So thank you all. Thank you so much for your time, and we hope you have a wonderful weekend. Happy Friday to you all.
Thank you. This was great.
Thank you all.